This is Critical Talk. I am Professor Amina Aldine, and today we're going to tackle some of the questions about healthcare. With us today, we have three distinguished physicians who've had too much education, and I will introduce them to you. We have Dr. Constance Shabazz, who is a physician originally from Chicago that does family medicine, but she currently resides in Austin, Texas. So I thank her for getting herself together to be with us today. She's president and founder of Health Resources Consultants. And recently, she was the senior director of Health Center Operations for Eman while it was getting its FQHC license. She also has a program that started during COVID-19 called American Muslim 360 Radio, and it's entitled Health Talk 360. She has, in addition to her MD and MBA and an MPH and a Master of Public Administration. We also have with us Dr. Padella, who is a clinical researcher and emergency room physician at the University of Chicago. His scholarship focuses on the intersections of healthcare, bioethics, and religion. He uses Muslim Americans and Islam as a model. He studies how religion impacts patient health behaviors and healthcare experience and informs the professional identities of the workplace of clinicians, which is one of the things we're going to talk about today. In addition to his MD, Dr. Padella also has an MSc in healthcare research and degrees in biomedical engineering and classical Arabic. Like I said, too much education here. We also have with us Dr. Hamada Al-Talib, who is the associate professor in the departments of psychiatry and neurology at Yale University School of Medicine. How he did this dual residency, I'll never know, in neurology and psychology, but he is the co-director of the Connecticut Veterans Healthcare System Epilepsy Center of Excellence. He is the founding and current editor-in-chief of the Journal of Muslim Mental Health and the co-founder and current president of the Institute for Muslim Mental Health. I think I have said enough. All of that was a mouthful, and we'll get down to business. Lots of stuff has been going on with COVID-19, but one of the major problems has been faulty, inaccurate, confusing communication. While we can't clear up all of that communication, I wanted to talk about one of the things that has struck me, and it's not because I'm inactive, folks, was everybody was telling folk, healthy, exercise, supposed to jump up and do exercise, get with it. This was somehow going to prevent us from catching COVID-19. For those of us who eat what tastes good and seriously meditate on exercise, those were instructions that we really couldn't see. I mean, what was that supposed to do? Jump up and get at my desk and start exercising? What was that supposed to do? Talk to me. I'm a patient.
Okay. Well, let me jump start it. It's when we are in the middle of any kind of crisis, health crisis of a more personal nature or a global pandemic, that we start thinking about what could we have done better to protect ourselves. And so I don't think the message should have been that all of a sudden with this pandemic that you were immediately going to be able to protect yourself from being infected and hope and die from it by making some dramatic changes. You know, in the immediate, you know, it's about saving a life and all of the life-saving processes that have to go on. But also, I think for many people, when they saw the statistics that came out, particularly among Black and Brown communities in this country, we knew that the outcomes of those communities in terms of the infection rate as well as the death rate was as a result of long-standing issues around healthcare disparities and self-care. So I think for many of us, and I'm a member of that community, it was a time of reflection. Okay, so what have I been doing and what can I change from here on out to change things? This may not affect in the immediate, but at least it has to be that kind of reflection and mental change in terms of what I want to do differently in terms of maintaining my health, because we don't really have a healthcare system here in the US. We have a lot of little bitty things that are clustered together that we call healthcare, but we know that the one thing that we have control of with Alliance Health is our own self-care. And we need to start looking at those things that we have the ability to address. And for those who don't have that privilege, you know, for those who are like in food deserts and things like that, that we have to, as much as possible, help to change that such that people will be able to have access to those things that will make an impact on their health in the future.
But people didn't want to hear, I'm just being antagonistic here. People didn't want to hear what's going to have an impact on my health care. I'm sitting here now, the TV is screaming at me about the numbers of deaths, the numbers of cases, and I really can't distinguish between cases and death. And I'm remembering a brief conversation with Dr. Padilla, and he described the situation to me that has really come to epitomize for me some of the things that were colliding in people's psyche when he talked about this woman who had come into the emergency room, I think you said 25 times.
So let me talk about that woman. But before I do, let me just say one thing, Professor Elty, that you might be hearing, or people might have been hearing about exercise, not as a preventive of perhaps COVID, but the idea was that when we have a situation that's going to cause people anxiety and stress, that exercise actually is preventive of mental health impacts, right? I think Dr. Hamada Al-Talib can speak more to that. But the idea that you should remain active as a way to prevent psychological outcomes that might be detrimental might have been one message that you heard. But the story that you pointed to, and I'll let Dr. Hamada speak about that in a second, but the story that you pointed to was the fact that for a lot of individuals, the scare of and the fear of what's going to happen and the lack of social support led them to use healthcare systems in different ways. So this lady I mentioned, she was a 93-year-old woman who did not have any children who were living. You know, she's in Southside Chicago. Her children were passed away because of all the things that happened in Southside Chicago. And so she was old, alone, and she had no social circle, but she was very, very worried that she would get COVID. And she was coming to the ER, and in 30 days, she'd come there 25 times to get tested for COVID with a variety of symptoms. She would say that, oh, I think I got it. Oh, I saw someone cough here. Oh, I saw someone do this. Oh, I saw in my building has it. I need to be tested. Both as a way to kind of get social connections with people because no one was visiting her. No one was going to check on her. But also deathly scared that if she got COVID, she'd be alone. No one would know. And then she would die in her own apartment without anybody ever checking on her.
Yeah. And I think that was a lingering thing of the loneliness, the confusion about symptoms, how you get it. The pundits that were on TV were not linking exercise to mental health. Some of us knew it was connected to mental health and continued to massage it in our heads as opposed to getting up out of the chair, but it wasn't linked to a way to damp down your anxiety. It was linked to vegetables. It was linked to now in a day or 24 hours, you got to change your whole menu. As opposed to if you get up and move around and do some other things, it'll, damp down your anxiety. Psychiatry person.
Okay, so that's my cue: anxiety and psyche. So
Yeah.
let me begin by thanking you for this opportunity and to share ideas with the distinguished guests. So I just had the clinic this morning, my telehealth clinic. I had this exact issue come up. I had a 78-year-old gentleman who has been stuck at home, been self-isolating, and has been very sedentary. He happens to have epilepsy as well as depression. He didn't want to take antidepressant medication. He was concerned about its effect on his epilepsy. I actually reassured him that in this case, taking antidepressant medication is actually safe for his epilepsy. But I did address this issue with him. I asked him specifically about his exercise because of this link that each of you have pointed out, that exercise helps mental health. And conversely, if you're sedentary and sitting at home, I explained this to him, he's going to get more and more stiff. He's not going to be able to exercise after days, weeks, months of sitting at home all the time.
Tell me about it.
So I told him was not to just jump up and start doing Zumba or salsas or whatnot, but to incrementally increase his exercise. Start by taking a walk, one block, see how it feels. Just loosen up those joints, and every week or every several days, as he tolerates, increase that by one block. And so for the first couple of days, maybe walk for one block, come back home. After another week, walk 2 blocks, come back home. Make sure his breathing is okay. Make sure his heart's not skipping a beat, and see how he tolerates it. And so that's one.
It also gets him out from in front of the TV, because I know Dr. Shabazz had talked about some of this on her radio program when the program first started, about the need. You're feeding the body, the soul, the joints. You're doing. It's a really wonderful smorgasbord of things that you're taking care of all at the same time.
Mm-hmm.
Absolutely.
Well, I'm sorry. One other thing though is one of the bigger issues, broader issues, is where people are getting trusted information.
Yeah.
All of these things that you're talking about, yes, they do have a positive impact in the immediate. I wasn't trying to say earlier that they don't, but where are people getting this information? And so trying to help navigate people to trusted sources, that to me is as big as giving somebody a dose of a virus. You know what vaccine rather. So we need to, as much as possible, provide people with information about what are credible resources for information. I say all health is local, because so if something is happening in New York, but here I'm in Austin, I need to be looking at what's happening here, as well as I need to be depending upon the resources here for information to help guide me through this. And so I think that's the role that we as healthcare providers play. I work with the community health centers. They have been at the forefront of the expansion of telehealth. There have been other systems that have been in place to reach out to people, because they know that people have been inundated with a lot of misinformation and information that gets old in 24 hours or less.
Yeah.
So, we need to make sure that we have systems in place to guide people to where they can get the right information, and also the resources. Like if we're saying exercise, well, telling a woman who's on the south side of Chicago in a gang-infested community to walk every day outside is very different from somebody who lives in California along the beach there. So we have to be sure that when we're giving people advice, we're also giving them information on how they can get the resources to actually fulfill that.
That is important, because in some areas you can't walk a block, Hamada, because people are checking you out to see how much money is in your pocket, or if you have your house key available so they can follow you home. I know that along with the community healthcare centers, the emergency room became an interesting sort of triage center. You had people with regular, I don't, that's a horrible term, regular mental health issues. I mean, the regular schizophrenia, this, that, and the other, who did not have COVID. You had the people who thought they might have COVID. You had people from broken arm, had, I don't know, digestive problems. How did the emergency room move to set itself up to distinguish? And some people who came in the door actually COVID.
So I think that for the last several weeks, a couple months, that the entire healthcare system has been one large emergency room. Really, that's what everything's developed into, right? So many places expanded. We knew that we have always known that the ER is the only place you can get care 24/7. It has an unfunded mandate. I'm told to see everybody, and that everybody from mental health issues, as you're saying, acute, chronic, urgent, to physical issues, was to come to the ER. That's why you all heard about flattening the curve. That we were the front door to the entire system, and all the non-essential, quote unquote, non-urgent systems in the hospital were shut down because we knew the deluge would come through the front door through the ER. So many hospitals, for example, our own, developed a tent. We had a tent outside in our ambulance triage bay where we would have patient flow coming through there, and then we would put them to 3 different sort of categories. Those who have potentially, initially, those who had potentially PUIs, potentially suspected COVID, those who have ILI symptoms, which we call people who have flu-like symptoms, cold, cough, we are suspecting have COVID, and those are just the regular, individuals who don't have either of those symptoms through a screener, a validated screener that entire country was using, so that we can now have zones where people aren't going to infect each other, right? You can imagine, for example, if we had a normal waiting room in the ER, 50 people sitting there, one person coughs in a small area, everybody can get infected. So that entire triage process was changed. And these new areas that we opened up, for example, a tent in our ambulance bay was manned, and we opened up actually an entire parking garage where internal medicine physicians from our hospital, people who weren't having clinics, were managing those patient flows. And the other issue, as I'll say, at that time when we started, this is in March, we were all worried about, and thankfully it's changed a bit, but there's still a problem in many places, about PPE, right? Because we were going to have enough masks, N95 masks, PAPRs, gowns, gloves, face shields, so that we can, as ourselves, health providers, stave off infection amongst our population. So it was really critical, not only for patient flow to be siphoned off in different sort of hot zones or potentially contaminated, potentially COVID and non-COVID, but also for providers. We couldn't go across bounds, right, virtual or physical, in the ER, because we would then infect others, or we might get infected. So the entire system changed, and for 2 months, the healthcare system has been operating in what I would say a large ER, right? This is what we do in third world countries all the time.
Yeah.
And now we're slowly, in some places, opening up to elective surgeries and clinics. As you heard from Dr. Hamada, a lot of the clinics were stopped, but then they had telemedicine. So I think the entire framework of healthcare is going to change. But what exposed, and I want to stop in a second, what's exposed is what Dr. Shabazz was saying, that our healthcare system is actually a disconnected aggregate of appendages and assemblages of workflows, but not connected together socially, right? And there's no connectivity at many places. And that leaves people, right, with large gaps in who they can see, when they can see them. And our ER is unsustainable to have we're dealing with this now. How are we going to continue to have this, and no vaccine, no cure, and manage the ER as we are with the patient flows? I mean, how are we going to do that? The providers are just a small group of people, right? The ER physicians.
Yeah. Dr. Hamada, you had something to add?
Right. So I actually want to circle back to what was brought up earlier about the context. And I want to make 2 points. And so we have a public health expertise here. And so one thing we talk about is the scale of clinical context, the person in front of us. So in my case, I have a person who lives in Connecticut in a relatively safe area. As you said, is very different than if you're living in an inner city that's in a rough neighborhood. And so there's a clinical context, but it's very important that we take into context also the public health context, which is at the population level. In other words, if you look at a population level, people are facing all sorts of different challenges. So you have some people who are directly impacted by COVID through themselves. Either they themselves have had COVID, are in the hospital, and are in an emergency situation or in the ICU, or their families are affected by COVID directly. And so they even may have lost somebody. A good number of hundreds of thousands of people, or millions of people around the world have lost somebody due to COVID.
Yes.
And so people are grieving. Even before COVID, many people have severe mental illness or moderate to mild mental illness, even before COVID happened. So they're bringing into this situation some baggage or some of their own challenges. Even if you don't have mental health issues or mental illnesses or mental health challenges, whatever dysfunctions or tensions they have at home or the challenges they have at home, whether they have kids or partners or employment issues, over 20 million Americans are unemployed now. And so that's a challenge. So we have to think in terms of a population level, in terms of what are the challenges to different groups, and appreciate that their anxieties and their kind of psyches are different contexts. In terms of, so across those people, so one issue is misinformation. The other issue is the reality people are facing. And so even if you don't have a history of mental illness or don't have a person who's directly affected by COVID, we are always thinking about COVID, even unconsciously, because when we walk out of the house, we have to wear a mask. We have to think who's going to be exposed. If we go to the emergency room, are we going to get it? What's the risk? So even if we're not consciously thinking of it, we're unconsciously thinking of it, and that increases our anxiety. And that takes a toll on the brain in terms of its ability to cope with the stress, because it's an added stress.
That's very true. We have, and all of you have alluded to it, is context and what information you're giving out, how accurate the information is. We have a wonderful president who said take hydroxychloroquine. So people ran around seeing where they could see this ingredient after they copied down how to spell it. And one man found it in his fish tank stuff and drank it because it was going to cure him. And he promptly, it did cure him because he's dead. You had others who, I know some patients use hydroxychloroquine for lupus and severe arthritic conditions, and I'm sure some other stuff I can't even think of. But then they had to fight to get their regular supply of medicine because physicians were writing prescriptions for friends. They even believed this, our president. And they were writing prescriptions for friends to get the hydroxychloroquine. It has, I'll say, uncovered some serious disconnects. But I want to talk about you all. You're on the front line. You're holding stern faces. You're shivering in your boots. Like, what is this person talking? Please don't give me whatever it is you got. No, I can't help every illness you may have ever had. And at the same time, other pundits are discovering how this particular virus acts. It's like a dribble of information. Well, it primarily affects the lungs. So everybody who has a cough runs to the emergency room to meet Dr. Padella. I got a cough. Somebody coughed on me. Other people found, well, my stomach is upset, but that's not the cough. So therefore, I don't have to go anywhere. The next thing by the time they get to Padella in the emergency room, they have to go straight up to the ICU. Other people had instances of stomach upset and diarrhea. The dribbling out of pertinent information was, due to not knowing and not having spent enough time before the mouth opened to give the patients information. But what was the effect on you guys? How have you maintained your health? You don't have time to go running around and jogging, and I'm gonna walk a block and then I'm gonna walk 2 blocks and let alone eat, period. Whether most of you are fasting, but eat, whether it's a vegetable or a sandwich or anything else before you're running off to the next instant. All of you teach, you got faculty meetings, you got telemedicine. Telemedicine is interesting. I'll come back to that. And how are you? I'm calling you doctor now. I am the arch doctor here.
So you're doing a therapy session here, right? Hamad is here and you're here. No, but before, I'll tell you about me. But I want to say something that in your comments, you're opening to this. The fact is, and for our listeners, the fact is that there will always be a dribble of information, because this is something that was unknown to mankind or humankind before late November. And that's the reality. And for everything catches up, knowledge comes after we have experience, and we're getting experience, and then we have knowledge, and things that we knew just 2 weeks ago have changed. So I think that this is something that is always part of science. Actually, we were doing very well in trying to get new tests. New research. Government's putting a lot of money in COVID-19 research. Everything else is sort of out the window. But if you have a COVID-19 idea, you can get funded very quickly. Because we're trying to figure out how to take care of the population health issues of this disease and how it manifests and what the predictors are. So I think that's just the normal march of biomedical information, and we're doing it very quickly since November. But in any case, that's the thing. As far as me, I think most of our obviously this is a largely Muslim panel. We're all fasting. I think Ramadan has been a way to focus on the important things and get rid of all the things that aren't important. I don't. Typically, we take some breaks from social media and other things, but because of the clinical work, I had faculty meetings twice a week. Every day we were getting new articles about how to take care of COVID patients. We were, as a public health person like Hamada is, I was dealing with the task force about mosque closing and things. So we had to look at epidemiological models about what's going to happen when we close, all these sorts of things. And in Ramadan, I said, I paused all that to the only extent that's necessary. I need to get up to fast and pray. I need to do my regular job. And I want to minimize all those other things, because I think that even for me, the cognitive burden is a lot, right? Just to take care of my patient, I need to do certain things, to advise those, I need to do certain things, but I can't imbibe everything. And what I've seen actually is that focus of Ramadan has helped people sort of maintain and become more resilient than they were before. And people who haven't done that, even in my own family circle, they're imbibing all sorts of conspiracy theories and all these sorts of things that are happening. I think that they're just struggling, and particularly because they're socially isolated, they're struggling even more. So that's how I maintained, focus on the ibadat of Ramadan, focus on those things that are farda ayn that I need to know to take care of those patients, let everything else go.
Translate some of that for our audience. Worship things. Yeah.
So things. So focus on the merits of fasting. What I need you to fast, right? Those, and then special prayers are not. I've been doing at home, reading some of the Quran, because this is a special month when the Quran was revealed. So it's a habit and it's a practice, recommended practice, to read more of the Quran, and then maintaining my family, right? So my family, 4 kids at home who are doing homeschooling, there's some responsibilities there. So those essential things to run the household and run my life and know what I need to know to take care of patients was what I was doing aside from Ramadan. Everything else, all the other social media, all the newsletters, all the extra talks one needs to go to, even some extra faculty meetings, all research meetings, all gone. I got rid of all of that because the cognitive burden and the allostatic load was too much, and it would have been too much for me.
But how do you tamp down your own anxiety? All of you are only human.
Oh, yeah. Well, I'm an ER doctor, right? So I think this is pretty different. We're wired. We are wired in a very different way.
Oh, crazy. But short of that, and in need of Hamada's help, but short of that, at some point, you gotta panic.
So, well, now here's the thing. I'll tell you, right? And I'm going to stop and let my panelists speak. But for me, as a person who, as I said, I've been dealing with this sort of Islamic bioethics and medical fiqh academy stuff as well. The only way out of this, for me as a religious person, is through attracting God's attention, divine mercy, and for him to uplift, right? No one's going to get me sick without his leave, and no one's going to get me cured if I were to get sick without his leave, right? And the risk, let's just be real, the risk of death from COVID-19 is less than 6%, 5% if you get it. So for me, how is that different? How is that different as a ER doctor?
I think the calculation is actually old, but
the different numbers: case mortality, actual mortality.
I might get it tomorrow.
Yeah, that's my point. So for me, all those stresses are. If you believe in that disease onset and cure is from a divine source, and that your remedy here, our knowledge is limited, is going to be through divine source. So for me, as I said, and the fact that I'm an ER doctor, this gave me some solace that nothing's going to change. with that as well. So I don't have to worry about those.
I understand that. I'm just pushing back, and I'll get to the rest of you because I got a bunch of time. Because this Black woman, day before yesterday, said, I'm not wearing a mask because God protects me, and I'm not going to get COVID if God doesn't want me to have COVID. Right. And I said, yeah, but God expects you to have some common damn sense.
I'm not disagreeing with you, right? So the tradition is right? So do your tie it and trust, tie your camel and trust.
Yeah.
I'm not saying that I wasn't wearing PPE, right? I'm not saying that I would go out with a mask. Actually, healthcare providers were mandated to wear masks by many hospitals before the government said that CDC said everybody should be masking. What I'm saying is that you can only control what you can control. And once you recognize that your scope of control is limited to the actions that you can do, like masking, right? Like I have right, masking here, and washing your hands and making prayer, then all the other anxieties of the possibilities go out the window. And for me, as a clinician, as a scientist, I am not worrying about improbabilities or possibilities. I am dealing practically what's in front of me, one foot in front of the other, to help my family, help patients, help myself. And so, as I'm saying, that's how I'm wired, right? That, okay, I can trust in God, but I can do my part, but not worry about, everything else. That's how I filter things.
Well, thank God, because you're in an emergency room. And I need for you to be wired. Mm-hmm. Which of you wants to next? What about you? How are you handling?
So I'm a psychiatrist. I'm wired differently than an emergency medicine doctor, but I'll summarize how I cope with COVID in 3 words: boundaries. I lost my train of thought. Boundaries. Exactly. Boundaries, structure, and self-care. Self-care being a hyphenated word. So boundaries is what Dr. Padala alluded to, is saying no, is knowing your boundaries, not to exceed your boundaries, not to exceed your capacity. And so I've said no, with exception to this interview, to a bunch of webinars, a bunch of invitations where people ask me to speak, mainly because there's so many other people speaking. There's so many other webinars going on. I didn't think there was much added value for me to do that. I knew my own boundaries. As Dr. Padala mentioned, just like him, I have kids at home. I have a wife that works full time. I'm working from home. I mean, right now I had to tell everybody I'm being interviewed on camera and it's live. We gotta shut the doors. Kids go and watch a movie downstairs, and so please don't interrupt. And so we have to manage all those people, all those things, and all those people. So one is boundaries. The second thing is structure. So imposing some structure. Whenever you have chaos, you try to impose some structure. So people. There's like a meme going around, a joke about kind of the blurred days. That's kind of we're not sure what month it is or what is it Thursday, Friday, or whatever the month it is, because everything blurs. We don't have a good sense of when is what because everything's so routine and mundane. So you impose structure, you impose a schedule to deal with that chaos. And so even with my kids, I have a schedule for them. For myself, I have a schedule for myself. And then I give myself a break. I give myself downtime. Being in the house all day in front of a camera, in front of a screen, doing it whether telehealth or meetings. I take, once that day is over, I go outside. I actually started a garden, which is new for me, learning how to, plant vegetables and just getting outside, going out for a drive by myself without, any other distractions. So, but that's part of a schedule. So boundaries, structure, and then the self-care piece is making sure that you make that priority. So all these things are interrelated. So doing the garden is part of my self-care, forcing myself to go out in nature and being away from screens and getting my mind off of all the madness. And then finding time to exercise. Even I give myself a break. I know I'm not going to do the normal workout that I was doing when I was in a better situation. But if I can do 10 minutes of working out every couple of days, that's fine. I mean, it's better than nothing. And so those are the 3 things that I recommend in terms of thinking about, in terms of what I've applied in my own life and what I recommend to other people to help deal with their situation.
Dr. Shabazz?
Yes. For me, it started out with me running a lot faster than I expected to with the radio program that we started. I was thinking about just doing your classical health and wellness program. And next thing I know, our first show was like the first week of the shutdown, staying home. And so my focus initially was to use my platform as a way of informing people about what the virus is, how people get infected, how to prevent infections. I spent time trying to debunk a lot of the myths and the conspiracy theories. And I mean, it was rolling for a while. Then I had to say, well, wait a minute now. With all of these things, all the information, and I know people are on information overload, myself included, I said, how do we actually address this in a more holistic way? So actually, alhamdulillah, the Masjid Al-Taqwa in Chicago started putting online programs. On Saturday, they had an exercise program, it was about the whole family. And so I started doing that. And I said, wow, this is really beneficial for me. Because I too, right before COVID, I was in the gym, 2-3 times a week. Wasn't going there anymore, And so, but I had an extra added advantage in that by doing it online, was doing it online with other people I knew. So there was a lot of socializing. Also following that, there was another program where we were learning meditation and deep breathing exercising. And so what I decided to do, especially when the data came out about the impact of COVID on African-American and Latinx communities, I said, you know what, we need to be looking forward and try to look at some of these modalities as a way of helping us with self-healing for now and for the future. So I said, well, okay, I started bringing on people on my show to talk about meditation, a woman who's a social worker and also a doctorate in acupuncture and Chinese medicine. I've had a health coach who did a piece on nutrition. Last week we did deep breathing, meditation. Next week is going to be yoga. So really, it was me sharing with people those things that I have found have helped me in my self-healing process. And what's been really great about it is that these are things that don't cost money. You don't have to necessarily go to a facility to do this. So for me, it's been self-healing, but also sharing with others. Another thing, I told people, I said, our Ramadan started early this year. Think about it. We were already pulling back. We were already more focused on others. How are they doing? Reaching out to people, making sure that we're connecting to them. And that, in a sense, helped us, relieve some of our own isolation by helping others who are isolated. So those are some of the things that I've done and have been very effective. I mean, it's been amazing. I've talked to so many Muslims, they said how at peace they are. And this is even before Ramadan started. So a lot of it has to do with, our own taking care of ourselves and being connected to Allah subhanahu wa ta'ala and looking at this as a punishment. Definitely as a trial.
Let me interrupt because we're getting into some very specific religious language. And to remind people, this is not a program on religion. It's not a program just for Muslims. All of you treat people who are not Muslims, want to know how are the physicians taking care of themselves. They've been introduced, you all talked about context. And one of the things I started asking questions about early was telehealth, which it's kind of always been around. I think it's an add-on to Epic or some of the other programs that the hospital uses. And I've always been fighting with physicians. Would you stop looking at the computer screen and look at me? I'll give you more information than that computer screen. But what can I say? Now we're asking patients to have tablets, to have computers, to know how to download programs. What to do if the program decides it doesn't work. Astute physicians will switch to FaceTime or Zoom or something, then the patient's got to figure that out. But then it's an issue between the hospital, insurance, and the physician with regard to getting paid. You can't do, what do they call it, elective procedures and surgeries all of those things. Hospitals are screaming, we ain't got no money. Some places are screaming, we want to open hospitals, like I think it's in Rosedale, whatever the suburb is in Chicago. You want to open a hospital, but then you don't have any money to open a hospital because you can't do all the things that are bringing in money. So context is indeed everything. But as you think about those things, are we changing the face of medicine? Can we change it in this way productively? And because I know that Dr. Padilla has to leave us, let him answer first.
So I think that healthcare in our society is going to change irrevocably because of this pandemic. And so I think telehealth, which Dr. Hamada had said that his clinics are working in that modality, we'll speak to that. I think we have the similar things in the ER. Believe it or not, we've had some places do telehealth triage for years, where physicians don't have to kind of be at the front lines. They do it remotely. So we are also doing that. We have telehealth follow-ups from the ER, right, for patients. So I think that's going to be an increasing modality. I have both. I think there's a promise, but there's a peril. The promise is that you can perhaps deliver quality care to certain individuals and protect, in this area, protect both patients and yourself from infectious diseases. The peril is that we think it's actually truly a substitute for high quality care sometimes, right? So all those people, like, alhamdulillah, thank God I have built internet at home and my kids can do homeschooling, right? Because we have multiple screens for them. But there are many people in our society who don't have that, as
right.
Right? And so the vulnerable in this are going to be left out as well, to some extent, who don't have access to these sorts of technologies, who don't have some healthcare plans don't reimburse the same rate for telehealth visits as regular visits, right? So you're going to have preferences given to certain populations and not others. You're going to have this, and I'll just say this as a physician, like I think that, as you said, Professor Aldine, the information I get from this, the cues that people give me in the ER, when I see them, when I can hear them, I get a lot more information than just seeing a face on the screen, right? And the human touch, right? Sometimes people are coming in for just the human connection. Like I told you, that 93-year-old lady, right? Wouldn't have been satisfied by just a telehealth visit. So I think we can't see them as totally replacing the art of medicine, the communication of medicine, but just as adjunctive measures for some populations. But if we think that that's how everything's going to happen, I think that we're going to just exacerbate the vulnerabilities and marginalizations in our society.
Thank you so much. I know that you have to leave. I am so happy that all of you could come because I know you all are all running between things. But thank you, Dr. Padilla. I know you have to disappear and go take care of the health of the soul. So I'll let you go do that, and I'll annoy you at another later date.
Appreciate it all. Thank you. Take care. Bye.
Okay.
Take care.
Dr. Hamada.
Okay, so I think we've talked about the misinformation, kind of all the challenges of COVID. So there's some good things that are coming out of COVID. The level of information has been shared across healthcare providers and researchers in such a rapid pace. It is unparalleled. I mean, just when we talk about flattening the curve, the amount of work that the institutions like Johns Hopkins and the CDC has undertaken to get that curve, to get this information, is extremely impressive. And I was just at an informatics meeting in the last 2 days, in which how that information is gathered and how do you make sure that information is correct and how do you validate that from private practice, from public community health, and from academic centers, all in one place to measure that curve. So the coordination of information has improved dramatically and very rapidly. The society, the everyday person, has got a crash course in epidemiology. I mean, just knowing how and talking about curves and talking about endemics and pandemics. I mean, we have a much more sophisticated language to think about these things and think about it collectively. And so some positive things. The telehealth, I think, is a very important technology that is going to change. It has changed. It has rapidly changed. And I've been trying to get our telehealth program. So I work at 2 places. I work at the VA hospital system, and I work at Yale University. Now even though Yale University is a very fancy Ivy League, top institution, the VA has been decades ahead in terms of rolling out telehealth, and it's because it's a centralized healthcare system. Now, the reason why it's so important, Dr. Bedell alluded to or mentioned kind of there's advantages and there's kind of benefits and there's perils.
Yeah.
I personally feel my bias is that the advantages far outweigh the perils. I'll tell you why. Number one is access to care. People, especially people in rural areas, sometimes drive hours to come to us. And literally, so I had a telehealth clinic this morning. I had 5 or 6 patients scheduled. Only 3 of them were able to do the screening, and we have to be flexible. If they can't do our healthcare system, we each of us have our own platform or software to go within our medical record to meet with a person through video. Then you have to be flexible. The advantage of that is that it protects a person's privacy because it's within the healthcare system.
Right.
When you go to Zoom or FaceTime or Google Chat, there's a risk that somebody can hack in and record what you're doing. There's a risk. Yeah. And so I think the benefit outweighs the risk. And so for each of those people, I asked them, which one do you prefer? And if 2 of them just didn't want to do the video chat, so we just had a phone conversation.
Right.
But nonverbal communication is hugely advantageous, just to see how people are doing and just to get the nonverbal communication when you're explaining something, if they're staring out or looking around versus if they're attending to you, you're communicating well. And so access to care is a major issue, and telehealth, I think, is going to improve it. And it's not just access to care in terms of the patient coming because of a distance. My patients have epilepsy; they can't drive, so they have to find somebody to either transport or somebody to drive them to see me. And some people have disabilities; it's very hard for them to move. So having the convenience of telehealth is very advantageous. The other thing is access to specialized care. I had a family friend who actually we both know, whose son is in his early 30s who had a stroke. And he was asking me and he lives in California, I'm in Connecticut. He was asking me, do you think it's from COVID? And I gave him my opinion, but I said, have you seen a neurologist? I mean, this is a stroke. I mean, you need to get a specialized care.
Right.
He said, no, I haven't been referred to a neurologist. Well, telehealth provides you more access to specialty and subspecialty services that if you don't have somebody in your location, you can call in or Zoom in or video chat with somebody in a different location.
Yeah. Dr. Shabazz, I know that you have been working in at least the last couple of years with another set of frontline folk in the clinics, the community health care clinics, supervising their way to get to, what is it, FQHC, federal health something.
Status, yes.
Yeah, but also looking to see how they're running. And COVID has changed the way, because I know you did on-site visits, because I've seen you do some of those, and COVID has changed the way that you talk to and see what's happening in these clinics. Can you talk a little bit about that?
Well, yes, but before I get to that, I just want to comment a little bit about the telehealth. That, I think most of us agree that it's an adjunct to our care, not a substitute. Okay, so it allows for us in a situation such as this, and imagine what it would have been like with COVID and not having that option, because a lot of people are still afraid to go to a physical setting for care. Now, it doesn't substitute, but it certainly gives an additional dimension to allow for, connectivity with the patient, to, get some feedback, what's going on. In the more advanced places that I've gone to that had used this for years, the acuity that you have with the instruments to do physical exams is better than the human eye can see. And so I've seen where it's been used very, very effectively. And the other thing that we haven't talked about is that we don't know what kind of fallout we're going to get in our healthcare community in terms of providers. So we are facing a huge potential shortage of providers. So that means that there may be providers who are servicing much broader geographical areas. Okay. So and there's no way that they're going to be able to do that, you know, traveling from one place to another. Okay. So this is going to be something that's really going to help us in the long run. Okay. So back to, you know, the question about, you know, the health centers and how are we making sure that they're doing, or how are they practicing now? What are they doing? Most of the health centers, they ramped up with the telehealth. They got right now probably, you know, several $1 billion worth of funding through the CARES Act. And so many of them have switched over to and incorporated the telehealth. As far as making sure, though, that they are still providing the quality of care. I think I shared with you recently that I and some of my colleagues did a virtual site visit with the health center. And I feel that we were still able to assess the quality of their care, even in a remote manner. So you still have to have the same criteria, you know, even though you may say, well, how do you know, if you're on site, you can really see things. Well, yes and no. A lot of it has to do with what you see. I mean, some of it, I should say, has to do with what you see, but also what you observe in terms of how they actually run their operation. So I don't think that there's been any breach in terms of the credibility of our assessments of the health centers. But I think that we will find over time, what the changes will be. It's evolving just like our knowledge of COVID is.
Well, I think that I know you brought up an extremely important point, because while there are positives for telehealth, it does enable you to expand geographically. I mean, even in a city. But what's going to happen when, as places open back up and those patients get used to this, as opposed to coming in so you can really see them? That's number one. What's going to happen to those things that you can't do over telehealth, blood draws, vaccinations, all of those kinds of things that still have to go on? And now we're faced with, because the communications has been so poor, people are scared to death to come anywhere.
Right. And that's going to be just like what's happening now with so-called opening up the economy. You can open up a shop, but that doesn't mean that you can force the customers to come in.
Right, to come in.
That's why I think it's very important in terms of where people get their messaging from. When I mentioned about all healthcare is local, I've started personally many weeks ago, stopped listening to the daily debriefs, which made no sense. They were just, but then I focus in on the messaging that's coming from our public health officials, okay? Because then they're telling us what's happening on the ground locally. And I think as people become used to those kind of more credible sources of messaging, then they'll say, okay, they'll hear, okay, we found that this is okay. We haven't seen any outbreaks when patients go to a doctor's office, okay? That's an important message. You know what I'm saying? And then we do, but most health centers have developed workarounds to ensure that those patients who do need to be seen, including my own health provider here, are seen, but in a safe environment. They've split up the type of appointments that they'll see. Right. They have special arrangements to limit exposure for those people who come in for blood draws and things like that. Right. And I think as time goes on and we see that the numbers, the data supports that, people are less and less at risk of going to their doctor and being infected, that we will see some of those aspects, hopefully, inshallah, that will resume. So we just have to, it's a wait and see. It's really a wait and see. But I understand, the fear. I mean, I just got a call last week and said, okay, you have an appointment. Are you coming in? And I said, no, because in my mindset, that's because the data doesn't support I need to come in right now. I'm comfortable about it. Okay. but I'm not basing it just on personal feeling. I'm actually following the data. You know, I'm tracking where the hot spots. You know, and also, you know, I know what I need. If it's something that I needed to actually physically be seen for.
Mm-hmm.
But see, you know, of course, I have that background. So
I think that Hamada is in for a deluge because all of us are crazy now. And
some of us more crazy than before.
Oh my God. I mean, I looked
mentally challenged.
Well, I've always been mentally challenged, but this is new. But I actually had a pad out. There are so many physicians on CNN, MSNBC. I said, who are these people? Where do you work? Why don't you all talk to each other before you talk to us? Because some of the information is so contradictory.
Right. So a couple of things. One is, again, from a public health level, from a population level, you know, about 50 to 80% of our outpatient visits, our clinic visits, have gone down. So most clinics around the country are only operating to 20%, at most 50% capacity. And so what's going to happen is there's a backlog. And so all the electives, all the regular follow-ups are backlog, because only, again, out of that 50 to 80% of people who didn't come to see the doctor in those couple of months, less than half of them actually did telehealth. And so there's going to be a backlog. So in terms of coming back to work, and that's why we still have faculty meetings, is because we're doing a lot of planning. And so the planning is, how do you prioritize, and what is appropriate for telehealth, and what requires face-to-face?
Right.
And so in general, I'll give you an example within my neurology department. So for instance, with epilepsy, once you've seen the patient once, you know, most of it's about asking them their seizure frequency, their response to medication, their overall health, and most of that is a conversation. It doesn't really take much of an exam. I mean, we do an EEG when necessary, and MRI when necessary. These tests we do, which we arrange, and quite frankly, I've even arranged home EEG, where we have the insurance cover the EEG to be done at the patient's home, as opposed to coming to the hospital and get risk of infection.
Okay.
But in contrast, with a patient with Parkinson's disease, which is a movement disorder where a person's shaking and they get stiff, those people really need to come in and be touched by the doctor so they can get an assessment of how bad the stiffness is. And so we were being very deliberate and prioritizing and selecting who needs to be seen face-to-face and who can be seen in telehealth. So my chief, when he asked me this, and again, based on data, based on information, I told him that before COVID, I had about 5% of my patients were being followed by telehealth, at most 10%. And right now it's 100%. I said, when we return to regular life, I'd like to shoot for the goal of 50%. That 50% of my patients will continue telehealth, because it's an opportunity to give them better access to care.
Right. Well, we're getting ready to close out. So starting with Dr. Shabazz, I know I didn't cover everything I needed to cover. I will come back to all of you and harass you some more as the next wave of craziness is supposed to come. You know, I don't know who Corona is, but she has made a mess of things for all of us. And as we get more stats, as we learn more about this virus, as we move on to perhaps, I've never seen a vaccine done in 60 days, but who am I? But at least as we get a way to if people have to go on ventilators, to get them off quicker, because they're going to have long-term use of a ventilator is special too. But if we can find a way to shorten the disease process so we can get them moving back to health. So I will be back to you, but I'm going to give the last few minutes to each of you.
Okay. Well, first of all, I want to thank you for I'm sorry. Okay. I want to thank you for the opportunity, and I'm glad that I was available to participate. I've learned so much from your guests, your other guests, co-guests here, and just want to say that as we know, this is a pandemic still in progress. We're learning so much about not just the disease, public health, but just health in general, healthcare. And hopefully we're all gleaning from this opportunities to make the system better.
Thank you. We're going to all be epidemiologists in the future.
Yes.
Last comments, Dr. Atala.
So I'll say that, behind the scenes, one of the inspiring things that we're experiencing during the COVID is the level of collaboration that's happening across healthcare professionals. I mean, you see in the news all the healthcare professionals who've stepped up in the front lines and really working those extra hours taking care of people who are really sick or at risk and putting themselves at risk. In addition to that, healthcare systems who are competing with each other, who, quite frankly, these are healthcare systems, they're competing for your business, are working together and collaborating quite a bit. And so there are a lot of resources that have been made available for the public and for the good of society. And so every city, every state has a COVID hotline. So if you have a question, there are many resources available, and you have to go to your local community to look at what COVID hotline is available for you. But there's multiple, and testing. We're very behind with testing, but it's going to ramp up, and we should get more availability with testing. But there are, because of the collaboration and the good intention of these healthcare providers, a lot of resources available for you locally.
That's great. Well, I can't thank both of you and Dr. Padilla, even though he's gone, enough for at the last minute entertaining my call in for help on a topic which I think we're going to revisit, because as we learn more, I think there needs some sage voices in here. What's happening in community health and public health, what's happening in the university, what's happening in veteran centers, what's happening in the emergency room. Those are critical avenues for us to have available to the people that come to listen to us. Muslim Network TV will launch shortly, and hopefully we will be able to have you back at an interval so you can put on your calendar. Is that? Yes. Calendar, people, calendar.
All right.
Thank you.
More than 24 hours warning.
I know. So I'm going to get on the calendar. Have a great day. Assalamu alaikum.
Wa alaikum.